Let's get a quick summary of what exactly these changes will be. First, the number of service levels will decrease from 5 to 4 for new patients. There will still be 5 levels of service for established patients. Second, history and physical exam will no longer be required elements in selecting a code or level of service. And lastly, selection of the code or level of service will depend on either complexity of medical decision-making or time. I will discuss these points later on in the presentation. Some other changes that we will see in 2021 are a new prolonged services code, newly revised medical decision-making guidelines, revised E&M code descriptions, revised times for existing E&M codes, and revised intros and guidelines for the E&M section in the CPT codebook. Now, let's discuss some of these changes in greater detail. A little while ago, I mentioned that the levels of service for new patients will decrease. This means that code 99201 will be deleted. The 4 levels of service for new patients will be codes 99202 through 99205. There will still be 5 levels of service for established patients, with the codes being 99211 through 99215. When it comes to selecting a level of service, history and physical exam will no longer be elements that are factored into code selection. However, in order to follow documentation best practices, providers should still perform and document all clinically relevant history and physical exams. So, if history and physical will no longer play a major role in selecting the level of an E&M visit, what will? In 2021, the level of an E&M visit will depend on either the complexity of medical decision-making or time. Will the MDM chart look the same in 2021 as it has in the past? The answer is no. Some major changes were made to the MDM chart. The current CMS table of risks was used as a foundation for the changes to the medical decision-making chart. The term independent historian has been added. The term mild has been removed from the description of levels of exacerbation for certain conditions. And lastly, the amount and complexity of data element was redefined, with categories 1 through 3 added to each level of medical decision-making from low to high. Let's talk a bit about time-based reporting. As I said before, the level of an E&M visit can be selected based on medical decision-making or time. The time reported is the total time on the date of service. So, this is total physician or QHP time on the date of service. It includes both face-to-face and non-face-to-face time. Time may be used to select a code level, whether or not counseling or care coordination is the primary service, and time can only be used for level selection for other time-based E&M services when counseling and care coordination is the primary service. So, a really important note here, if you are reporting based on time, it is highly recommended that your time be documented in the record. Slides 9, 10, and 11 show the new MDM tables. If you look at the headings on the chart, you can see that the major elements involved in the selection of MDM level are the number and complexity of problems addressed, the amount or complexity of the data to be reviewed and analyzed, and the risk of complications and morbidity and mortality of patient management. Some of this should seem familiar because many of these elements can be found in the current MDM table. I know the charts may be a little bit hard to read, so we will make sure that these tables are available for you to download separately. Note that for the moderate level of MDM, the amount and/or complexity of data to be reviewed or analyzed requirement is one of the 3 categories presented. For the high level of MDM, The amount and/or complexity of data to be reviewed or analyzed requirement is 2 of the 3 categories presented. And again, we will make sure that these tables are available online for downloading and for printing. Let's talk about the new Prolonged Services Code 99XXX. This code can only be reported with codes 99205 and 99215. It cannot be reported with any other code. You can only report this code when the visit is based on time, so you can't report it if the code is based on medical decision making, and after the total time of the service has been exceeded. The increments will either be in 15 or 10 minutes depending on if it's an established patient or a new patient. Slides 13 through 16 show the revised code descriptions for new patient E&M and established patient E&M codes. I won't read the revised descriptions for all 9 codes, but I will point out the major changes. All the revised descriptions mention something about having a medically appropriate history and physical, which is vague intentionally. The emphasis is placed on the medical decision-making and time. The levels of MDM are straightforward, low, moderate, or high. The time requirement is presented as a range of total time spent on the date of the encounter. And remember, total time includes both face-to-face and non-face-to-face time on the date of the encounter.